The link between obesity and cancer is now well established in medical science. But what is often overlooked, if not actively ignored, is that this deadly connection does not affect all populations equally. In fact, the risk, progression, treatment response, and survival outcomes of obesity-related cancers are deeply shaped by social determinants of health. Income, education, housing, neighborhood environment, systemic racism, and access to care. These invisible forces form a dangerous, often fatal, backdrop to an already rising global health crisis. Without addressing the root inequalities behind the obesity-cancer link, we will never close the widening gap in cancer mortality between rich and poor, urban and rural, Black and white. At every stage of the cancer pathway, from risk exposure to diagnosis to survival, those living in poverty or facing structural discrimination carry a disproportionately heavy burden. Obesity is more prevalent among people with lower income and educational attainment, particularly in marginalized racial and ethnic groups. But this is not merely a reflection of bad choices or personal responsibility. It's a reflection of environments engineered for illness. Food deserts filled with ultra-processed products, unsafe neighborhoods that discourage physical activity, and relentless marketing of unhealthy products to communities of color and low-income families. For example, in many urban and rural areas across the U.S., healthy food is either unaffordable or physically inaccessible. Residents may rely on dollar stores or fast food chains for daily sustenance, consuming calorie-dense, nutrient-poor diets that drive weight gain, inflammation, and metabolic dysfunction. Meanwhile, underfunded schools eliminate physical education, and green space is a luxury, not a right. The architecture of daily life in these communities is toxic by design, and the result is higher obesity rates that fuel higher cancer risk over time. But the disparity doesn't end with increased incidence. Once cancer develops, the divide often becomes deadlier. People with obesity from low-income backgrounds are more likely to experience delayed diagnosis due to barriers in accessing preventative care. Many lack insurance, a regular physician, or the resources to take time off work for screenings. For some obesity-linked cancers, like colorectal or endometrial cancer, early symptoms can be dismissed or missed entirely, especially in individuals whose weight obscures physical signs or whose complaints are minimized by providers. Even when diagnosed, treatment disparities persist. Obese patients from disadvantaged backgrounds are more likely to receive substandard care, face longer wait times, and have limited access to advanced therapies or specialized oncology centers. Implicit bias plays a role too. Patients with obesity, particularly women of color, are often stigmatized in healthcare settings, leading to less aggressive treatment plans or poor communication around treatment options. This bias, combined with lower health literacy and systemic mistrust, further reduces engagement with cancer care and follow-up. Survival rates reveal the devastating toll. Non-Hispanic Black populations, for example, are disproportionately affected by obesity-related cancers like colorectal, pancreatic, and uterine cancer, and they experience higher mortality across nearly every major cancer type. This is not simply a reflection of biology. It is the product of a healthcare system that routinely fails to serve those it was never designed to protect. The compounding effects of poverty, racism, and obesity form a feedback loop of poor outcomes, shortened lifespans, and generational trauma. Rural communities are also at high risk. Often overlooked in national health conversations, these populations face unique structural barriers: long distances to cancer centers, limited availability of oncologists, and greater rates of poverty and obesity. Many rural residents live with undiagnosed or untreated metabolic conditions for years, until cancer emerges, often aggressively, and too late for effective intervention. The solution is not simply to tell people to lose weight. That narrative is not only ineffective, it's insulting. Obesity must be addressed as a disease of inequality, and cancer prevention efforts must expand far beyond the clinic. This means investing in public infrastructure, building affordable grocery stores in food deserts, subsidizing healthy food options, creating walkable communities, restoring physical education, and combating discriminatory marketing practices. It means reforming healthcare systems to ensure universal access to screenings, culturally competent providers, and unbiased cancer care. It means acknowledging that health outcomes are deeply political and that silence is complicity. Medical education must also shift. Providers must be trained to recognize and mitigate bias against obese patients, especially those from marginalized backgrounds. Researchers must include diverse populations in trials to ensure that obesity cancer treatment strategies are effective across racial, socioeconomic, and gender lines. Policymakers must stop pretending that body weight exists in a vacuum. The obesity cancer crisis is not just a biomedical issue. It is a justice issue. It is a reflection of centuries of inequity, now manifesting in cellular damage and premature death. Until we tackle the systemic conditions that shape who gains weight, who gets sick, who gets care, and who gets cured, we will remain locked in a cycle of preventable suffering. The weight of inequality is crushing. It's time to shift it.